Our next speaker is Katy Kozhimannil, Director of Research at the Rural Health Resource Center and an Associate Professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. And we're so grateful she's here with us today to share her research and her incredible expertise on the rural obstetric workforce, as well as federal and state policy opportunities. Katy?
Hi, everyone. I'm so pleased to be with you this afternoon. I have a chance to follow my fantastic, tell you a little bit about the research that we have done looking at what folks in rural communities experience with respect to maternity care and the workforce. So I want to start off by acknowledging my amazing group of collaborators and our wonderful federal funders. This work that I'm going to present today is a quick consolidation of research that's a range of different projects that we've done looking at maternity care, access and quality, and workforce in rural areas that's funded by the Federal Office of Rural Health Policy at HRSA. And I also want to acknowledge my colleagues at the Rural Health Research Center at the University of Minnesota and our advisory group. We have had a fantastic obstetric care advisory group that consists predominantly of obstetric nurse leaders in rural hospitals across the country. And we've learned so much of our work is informed by the experiences of women, families, communities, and those that are on the ground and doing the work on a day-to-day basis. So I really want to acknowledge with gratitude everything that they've contributed. So I'm going to move forward. I'm going to provide a very brief bit of background context, and then what I want to do is present some kind of high-level research findings. It's a little different than what we've heard so far on this webinar, but I want to bring to bear the data that we have uncovered in our work in looking at who is providing maternity care in rural communities. So we've heard a lot about childbirth generally being both the most common and most costly reason for hospitalization in the U.S. About 500,000 babies are born in the rural USA every year. So there are a lot of people that need maternity services in rural communities. About half of all births are covered by Medicaid across the United States, and that percentage is higher in rural hospitals compared with in urban hospitals. And all of the discussion that we're having today around maternity care access is happening in the context of declining access to obstetric services in rural communities. And this follows on. I'm not going to focus on this today unless there are questions that come up around it, but our group has recently published a couple of policy briefs that have highlighted the reduction in access to hospital-based obstetric services in rural counties across the U.S. So between 2004 and 2014, 179 rural counties lost access to hospital-based obstetric services. And that meant by 2014, more than half of rural counties had no obstetric services. We also found that closures were more common in more remote, less populated rural communities in only about 40% of non-core rural counties. So that's the way that we measure this. We've got metropolitan counties, which are urban areas, micropolitan, which are counties that have small towns, and non-core, which are rural counties that do not have sort of even a micropolitan-sized town. So we also found when we looked at this is a lot of variability across states. And one thing I just wanted to highlight here is that some states have a wider swath of rural counties that do not have access to obstetric services. And I'm using the term obstetric here. I recognize that language matters, and I guess I want to correct myself and say maternity care and talk about maternity care more broadly. So here are the states that have very high percentages of their counties without any hospital-based maternity services. So there are many places where there's declining access to services, but in the rural hospitals that do provide maternity care, who is providing those services? We set out to answer that in our research, which I will describe. And we looked at, what types and combinations of clinicians are delivering babies in rural. What's the relationship between hospital birth volume, the number of births that are happening at each hospital, and the staffing models at those hospitals? And what are the staffing challenges that rural hospitals are facing? To answer these questions, he used data from the Federal Healthcare Cost and Utilization Project. The statewide inpatient databases are a census of all hospital discharges in, you'll see the 9 states that are highlighted in yellow, hospital discharges. And we studied all the hospital births to rural residents in these 9 states. In addition, because information on who's providing care is really difficult to come by, we conducted a telephone survey of all 306 rural hospitals in these 9 states that had at least 10 births in 2010. And we called up these hospitals between November of 2013 and March of 2014. We had a response rate of 86%, so we heard from 263 of those hospitals, and most of the results that I'm going to present today derive from the answers that we got from calling up the obstetric nurse managers predominantly in these hospital settings. So I'm going to gloss over methods pretty quickly, but if anyone is really interested in understanding the numbers and how we got to them and the methodology or analytic tools that we use, I'm happy to talk more about it. We divided rural hospitals into quartiles by annual birth volume, looking at low-volume hospitals, those with between 10 and 110 births a year, medium volume between 111 and 240, medium high, which is 241 to 460, or high birth volume, which is more than 460 births a year. Now, to some of you, that may seem like what we're calling high birth volume may seem like low birth volume in a lot of urban settings. I think that's true, but I want to take some time to think about that because the rural setting is very different. It has important implications for what hospitals can afford in terms of staffing and employment, as well as private practice models and how they're able to sustain themselves financially or not. So we conducted multivariable regression analysis, and we also did qualitative analysis of the open-ended questions that we asked about workforce changes and staffing challenges in rural hospitals. So I'm going to show you a few of our results. So this slide shows just the average number of obstetricians or family physicians that were in surveyed rural hospitals that were attending births in these hospitals by birth volume. So on the left, you have among all rural hospitals, you have an average of just over 3 of I don't even think we can see, so just over 3 obstetricians. I'm not sure if you all can see the reddish bar is obstetricians, and family physicians are in blue. Ooh, that is there. Okay, great. Double checking my slides while I present. And just over 4 on average that are delivering babies, family physicians in rural hospitals. But you can see that pattern differs dramatically by birth volume, with kind of an increasing number of obstetricians attending deliveries with birth volume, and a different pattern for family physicians. First of all, I want to note that especially in the lower volume settings, there are more family physicians that are providing maternity care services than there are obstetricians. So certainly when we're having discussions around the maternity workforce in rural areas, family physicians are absolutely an integral part of that discussion. And I think that this slide makes that very clear. Next, I am going to look at see if that's coming up. There we go. The percentage of obstetricians and family physicians that are employed by the rural hospitals that we talked with. So you have folks that are in private practice versus those that are employed by the hospitals, and the hospitals have different strategies of attracting and retaining maternity care clinicians. So what you see here is that obstetricians are on the left side of the vertical line here. Almost 60% of all obstetricians that attend births in rural hospitals in these 9 states are employed by the hospital, and that's about 40% for family physicians. And you can also see a different pattern over time with a higher percentage of clinicians, both obstetricians and family physicians, but especially obstetricians, employed in lower birth volume settings compared with higher birth volume settings. And that relates to the financial feasibility of private practice models versus the need for a hospital to actually employ and guarantee that salary and revenue for their providers. Next, I'm going to turn to a discussion of the nursing workforce. So I have one slide here on these results. We have a whole paper on this topic, and would encourage those of you that are interested in this topic to take a look at that. But one of the top challenges, and we'll get there in a moment, that we heard from rural hospitals was it was not just about attracting maternity care clinicians in the form of physicians, obstetricians, family physicians, or midwives, but really around high qualified recruiting and retraining a highly qualified nursing workforce as well. One of the major differences we saw by birth volume was whether rural hospitals reported having dedicated nurses that worked only in labor and delivery in the postpartum unit, or whether they were shared across different service lines in the hospital. And that was really strongly determined by birth volume, with hospitals with fewer than 300 births. Almost 80% of those hospitals had shared nurse staffing across units. And next, I'm going to provide a few results as they relate to the practice of midwifery in rural hospitals. In this survey, we asked about whether midwives attend births at hospitals, and we found that CNMs attend deliveries in about a third of rural maternity hospitals in the states that we studied. And there was a lot of variability across states, which may relate to state scope of practice laws, which we've already discussed. In rural hospitals that provide maternity services, CNMs practiced alongside obstetricians in 86% of those hospitals, and they practiced alongside family physicians in 44% of the hospitals, again highlighting the important role of family physicians in rural maternity care. We also found that larger volume rural hospitals were more likely to have CNMs attending births compared with lower volume rural hospitals. And when we talked to rural hospitals about their plans for the future, many, more than half, said that their future plans included trying to recruit midwives to practice maternity care at their hospital. And that was a very aspirational statement. And obviously, as we know, recruitment and retention are challenging, but that's a big issue on the minds of rural hospitals that are hoping to meet their maternity care needs. So when we talk about, what rural hospital obstetric unit managers mentioned as particular staffing challenges, there were a number of issues that came up. Scheduling was the most frequently mentioned challenge, especially when you have low birth volume or variable birth volume. It's very difficult to consistently staff a unit. These scheduling challenges were also related to work-life balance issues and how frequently providers needed to take call, as well as challenges with respect to sharing nurse staffing across different units of the hospital. Training and making sure that people were able to keep up their skills was mentioned by 23% of hospitals. Recruitment and retention by 20%, just over 20%. Census fluctuation, so this idea of birth volume, moving up and down and needing to have resources immediately available when there is a birth, and the unpredictability of birth was mentioned by almost 20% of the hospitals. And intra-hospital relationships was mentioned as a staffing challenge, again, relating to shared nursing staffing and also to the use of scarce resources in rural hospital settings. Obstetrics was frequently cited as one of the most commonly cited reasons for closures of obstetric units is that service line is not as financially lucrative as others. And when there's a battle for resources, often the service lines that generate the least revenue lose out with respect to gaining access to additional resources for staff recruitment, retention, training, some of these other challenges that we see listed here. So that's a part of this story as well. So in summary, we found that rural hospitals with lower birth volume were more likely to have family physicians and also general surgeons, which I didn't mention here, but are also an important part of the maternity care workforce in especially small volume rural hospitals. We found hospitals with higher birth volume more frequently having obstetricians and midwives attending deliveries. We found that employment of physicians decreases as birth volume increases in rural areas, and that three-quarters of rural hospitals with fewer than 300 births a year have shared nurse staffing. Midwives are an important part of the rural maternity workforce, attending deliveries in a third of rural hospitals. And the workforce challenges that were reported by surveyed hospitals tended to relate very strongly to their rural or remote location and to low and variable birth volume. I'm going to turn now to a very brief discussion of some of the things that we can consider in the way forward with respect to national policy and state policy. And I'm not going to spend a lot of time here because we've already heard a really in-depth discussion on the Improving Access to Maternity Care Act. I just want to emphasize in the context of rural maternity care how important the health professional shortage areas designation has been for rural workforce shortages generally, and how specifically important this could be in rural settings to designate maternity care shortage areas. At the state and local level, there are a lot of different things that can be done. We've heard about state scope of practice laws. I want to re-emphasize Medicaid policy, which are broadly determined at the state level. Again, Medicaid funds half of all births in the U.S., and so the policies that it sets with respect to coverage, benefits, reimbursement rates, payment policies, and managed care arrangements they play a strong role in access to maternity care and in the maternity care workforce. All of this is in a little bit of flux right now as we see from the federal level a greater push toward more state autonomy, more state flexibility in how they implement their Medicaid programs, and so this is going to be something to keep a close eye on in the years ahead. And just a brief mention of other state and local efforts. I know we have a lot of folks on the line today from states, and there have been a number of, I can't emphasize enough how important the state level policies are in really shaping who can provide maternity care, who is providing maternity care in rural areas. And there are efforts toward homegrown rural workforce, so training folks from rural areas, ensuring that there are professional schools in rural areas or rural tracks to training programs, encouragement of rotations that include obstetrics and maternity care in rural areas, including in family medicine, and subsidies for continuing medical education and other ongoing training capacity. We've discussed this briefly, but CMEs and other ongoing training opportunities, including interprofessional training opportunities in rural settings, is extremely important given how much you see interprofessional collaboration in terms of practice of maternity care in rural areas. Again, state and institution level quality improvement initiatives and collaboratives can help to leverage resources across different small volume settings. So in rural communities, you often don't compete with the nearest other hospital providing maternity services because it's likely to be quite a distance away. And because of there's sort of not competition because of geography, there's a greater incentive to potentially collaborate and share resources. For example, getting a simulation van that goes across a region. I know there's a collaborative of small rural hospitals in Wisconsin that does this. They pool their resources to have a mobile simulation unit to train their staff on how to respond to obstetric care emergencies. So we have to look for opportunities for ways to address some of the staffing challenges that rural hospitals have noted. And that's everything that I have for you today. I've put up a few links here for additional information, if any of those would be helpful to you. And I thank you for your time and attention today and welcome any additional questions.